Welcome back to the Deep Dive. Today, we are doing something a little different and, honestly, a little bit daunting. We are just skimming the surface of an article or, looking at a pop science summary. We are rolling up our sleeves, scrubbing in, and going straight to the bedrock of surgical knowledge.
That is right. We are pulling a very, very heavy book off the shelf today. If you're a medical student, a surgical trainee, or just someone who wants to understand the absolute nuts and bolts of how modern medicine works, you know this book. We're diving into Baily and Love's Short Practice of Surgery.
And specifically, we are cracking open the 28th edition to Chapter 68. The title is Bariatric and Metabolic Surgery. Now, I want to set the stage here immediately. This isn't just a chat about weight loss.
Not at all.
This isn't about fitting into a wedding dress or getting a beach body. The text opens with a statement that is, well, it's incredibly stark. It calls obesity the plague of the 21st century.
It is a powerful way to frame the discussion, isn't it? And before we make the first incision, let's define our mission here. We're treating this deep dive as your ready reckoner. If you're revising for exams, or if you're a junior doctor about to start a rotation on a bariatric firm, this is your scaffold.
Right. We're going to build the structure in your mind, the definitions, the operations, the anatomy, the scary complications. But, and I cannot stress this enough, this is an interpretation.
Yes.
We're using metaphors and memory anchors to help this stick, but this is not a substitute for reading the book.
Absolutely not. You need to keep Baily and Love handy. Read Chapter 68, look at the diagrams. Our goal is that when you read it after listening to this, you'll be nodding along going, aha, I know exactly why the angle of his matters.
So let's get into it. Section 1 covers the paradigm shift. I think for a long time, and certainly in the media, obesity has been framed as a behavioral issue. The old gluttony and sloth model.
Eat less, move more.
Eat less, move more. Exactly.
And Baily and Love completely dismantles that view right out of the gate. The text frames obesity strictly as a disease. It's a chronic, relapsing disease process. It's not a failure of character. It's a failure of physiology.
Okay.
And to treat a disease, you first have to define it with precision.
Let's look at the numbers, because exams love numbers. The text utilizes the World Health Organization definitions.
These are the global standards, so let's verify your baselines. Overweight is defined as a body mass index, or BMI, greater than 25.
Okay, greater than 25.
Obesity starts at a BMI of 30, but the surgical territory, the area where we start sharpening the scalpel, is what the text calls severe and complex obesity.
Define that for us. What does severe and complex look like on a chart?
So we're looking at a BMI greater than 35 if the patient also has a significant obesity-related disease. We call them comorbidities.
Right, like diabetes.
Things like type 2 diabetes or hypertension, exactly. Or we're looking at a BMI greater than 40 just on its own, regardless of whether they have other diseases yet.
And the text drops a statistic here that I found genuinely chilling. It says severe obesity can reduce life expectancy by anywhere from 5 to 20 years.
That's a massive chunk of life. Think about that. 20 years. That's seeing your grandchildren grow up. That's an entire retirement.
Wow.
And it's not just the duration of life, it's the quality. The text lists the impact. Type 2 diabetes, hypertension, obstructive sleep apnea, joint failure, and a significantly increased risk of cancer.
So if the stakes are that high, life and death, why do we need surgery? Why can't we just put people on a strict diet? The text has a very specific explanation for why diets fail, and it uses a concept I love, the homeostatic set point.
This is the crucial concept to understand. It really is. Think of your body weight like a thermostat in your house. Let's say your thermostat is set to 20 degrees.
Okay.
If you open a window and it gets cold, the heater kicks on to bring you back to 20. The text argues that people with obesity have a broken thermostat. Their set point is dialed up way too high.
So if a patient with obesity goes on a diet, what happens to the thermostat?
The body doesn't see that as a healthy choice. The body perceives it as starvation. It thinks there is a famine. So what does it do?
It fights back.
It fights back. Hard. It drastically drops the basal metabolic rate to conserve energy. It floods the brain with hunger hormones like ghrelin. It makes you lethargic. It essentially drags you kicking and screaming back up to that high set point.
That explains the yo-yo effect. You lose 10 kilograms and the body fights to put 12 kilograms back on.
Exactly. And that is why the text states that for this specific population, those with severe and complex obesity diet and lifestyle interventions have a long-term failure rate of about 95%.
95%.
It's not a lack of willpower. You are fighting millions of years of evolutionary biology designed to keep you from starving.
And surgery is the only thing that actually resets the thermostat.
Correct. Bariatric surgery is currently the only treatment that effectively lowers that set point, allowing the patient to sustain a lower weight. And we have the data to back this up. Baily and Love relies heavily on a landmark study here, the SOS study.
The Swedish obese subject study. This seems to be the holy grail of bariatric data. Why is it so important?
Because of the timeline. In medical research, getting data over a year is easy.
Sure.
Getting data over 5 years is hard. The SOS study started in 1987 and followed patients for over 20 years. It compared those who had surgery against those who had standard medical therapy diet, pills, advice.
And the result wasn't just about, what size pants they were wearing.
No, and this is the key takeaway for your exams. The headline of the SOS study is survival benefit. Patients who had surgery lived longer. They had reduced overall mortality, and specifically a significant reduction in cancer risk. There was also the Utah study mentioned in the text with nearly 8,000 patients, which showed a massive reduction in cardiovascular events, heart attacks, and strokes.
So when a surgeon suggests this operation, they aren't offering a cosmetic tweak, they're offering life extension. This brings us to a terminology shift that I found really interesting. The chapter title uses both words, bariatric and metabolic.
Yes. Bariatric comes from the Greek word baros, meaning weight. That was the old way of thinking. We're doing surgery to reduce weight, but metabolic reflects our modern understanding.
We're doing surgery to treat the metabolic syndrome?
Precisely. That deadly cluster of high blood sugar, high blood pressure, and bad cholesterol. We are operating to fix the metabolism, not just the scale.
Right.
And there's a nuance in the language regarding diabetes that I want to highlight. In the early 2000s, there was a lot of excitement about a cure for diabetes.
Yeah, I remember that.
Baily and Love 28th edition is a bit more cautious. It's more precise.
It uses the word remission.
Right. Remission is the scientifically accurate term. It means the patient has normal blood glucose levels without needing any medication. But we say remission because diabetes is a chronic progressive disease. If the weight comes back.
The diabetes can come back.
It can. But still, imagine putting a disease like type 2 diabetes into remission for 10 or 15 years. That saves kidneys. That saves eyes. That saves limbs from amputation. It's huge.
Okay, we've established the why. It is a disease, the thermostat is broken, and surgery resets it to save lives. But let's get practical. Let's talk about the who actually gets onto the operating table.
This is a great moment for a check-in. I want you, the listeners, to pause for a second. Don't just listen passively. Ask yourself right now, what are the current NICE guidelines for bariatric surgery eligibility? Can you list them?
Oh, okay. Hopefully you've got an answer in your head. Let's see if you are right.
The standard criteria have been around for a while. You're eligible if your BMI is greater than 40, regardless of your health status.
Okay, BMI over 40, you're in.
Or if your BMI is between 35 and 40, provided you have a significant comorbidity like diabetes or hypertension, that would improve with weight loss.
But wait, there is a new lower threshold mentioned in the 28th edition? This is the bit that might catch people out.
This is the game changer. NICE now suggests considering assessment for people with a BMI of 30 to 34.9, so just barely crossing the line into obesity if they have recent onset type 2 diabetes.
Define recent onset. What are we talking about?
Usually, we define that as diagnosis within the last 10 years. The logic is, if you catch the diabetes early enough, before the beta cells in the pancreas have burned out, surgery can completely reverse the disease process. If you wait until they hit a BMI of 40, you might have missed the window to save the pancreas.
There's also a very specific note about ethnicity.
This is crucial for clinical practice. The text notes that for Asian populations, the metabolic risks, the diabetes, the heart disease, kick in at a much lower BMI than in Caucasian populations.
So the same rules don't apply?
No. The threshold for offering surgery should be lower for these groups. Specifically, the BMI threshold is reduced by 2.5 points. So obesity is defined as BMI 27.5 for Asian populations in some contexts. You need to be aware of this or you will undertreat a high-risk population.
So you have a patient who meets the criteria. They don't just walk in and get a bypass on Tuesday. The text talks about the MDT.
The multidisciplinary team? Surgery is not a solo sport anymore. You need the village, you have the surgeon, obviously, but you also need a specialist, bariatric anesthetist, a dietitian, a psychologist, and a physician. They all have to sign off on the patient.
I can understand the dietitian, but why the psychologist?
They aren't there to block the surgery. They are there to ensure success. They look for barriers. Are there undiagnosed eating disorders like binge eating?
Right.
Is there a lack of support at home? Is the patient psychologically prepared for a life-altering change? Surgery is just a tool. If the patient doesn't have the mindset to use the tool, it will break.
Okay, so the whole team agrees. The MDT says yes. Now we move to the physical prep. And this involves something called the liver shrinkage diet. This creates a very vivid image in my mind. Why are we shrinking the liver?
Visualize the anatomy. Almost all bariatric surgery is done laparoscopically now, keyhole surgery.
Right.
You make small cuts, blow up the belly with gas, and use long instruments. Now, where's the stomach? It's tucked right up under the left rib cage, and what is sitting right on top of it?
The liver.
The liver, specifically the left lobe of the liver.
And in a patient with severe obesity, that liver is big.
It's often huge. We call it hepatomegaly. It's filled with fat steatosis. It's heavy, it's thick, and it's friable, which means it tears easily.
Oh, wow.
To get to the stomach, the surgeon has to lift that heavy liver up and hold it there. If the liver's full of fat, it's like trying to lift a wet, heavy block of tofu with a metal stick. It cracks, it bleeds, it blocks the view.
So the diet dries it out, makes it firmer.
Exactly. The patient goes on a very low-calorie, low-carbohydrate diet for 2 weeks before surgery. This forces the body to use up the glycogen stores in the liver. Glycogen holds water, so as the glycogen goes, the water goes. The liver literally shrinks in size, becomes firmer, and makes the surgery infinitely safer and easier.
Before we put the patient to sleep, we have to assess the risk of death. The text mentions a few scoring systems, but the OSMRS seems to be the one to memorize.
The obesity surgery mortality risk score, yes. It's a classic because it is simple. You get 1 point for each risk factor. There are 5 factors.
Okay, let's hear them.
Let's count them off. 1, age greater than 45. 2, BMI greater than 50. We call that super obesity. 3, male gender.
I always find that one interesting. Why is being male a risk factor for surgical death?
It comes down to fat distribution. Men tend to have visceral adiposity. That's the hard, apple-shaped beer belly. The fat is packed inside the abdomen around the organs. Women often have subcutaneous fat pear-shaped. Visceral fat makes the surgery technically much harder because there is simply no room to work inside the belly. It's tight. Plus, men generally present later with more advanced metabolic disease.
Okay, so age, BMI, male gender. That's 3. What's number 4?
4 is hypertension. And 5 is having risk factors for pulmonary embolism, PE, like a history of clots. You add up the points. Score 4 or 5 puts you in the high-risk category.
There's one more risk factor the text highlights specifically regarding leaks, which is sleep apnea.
Yes. Obstructive sleep apnea, or OSA. This is a vital clinical pearl. The Swedish registry data suggests that having untreated sleep apnea is an independent risk factor for anastomotic leaks.
Why? Is it the pressure changes in the abdomen?
We think so. Think about the mechanics. You stop breathing, your airway closes, and then you gasp. That gas creates a massive negative pressure in the chest and abdomen. It physically yanks on the fresh staple line of the stomach.
Wow.
So treating OSA with a CPAP machine before surgery isn't just about sleep quality. It is literally about keeping the stomach intact.
Okay, the patient is prepped, the liver is shrunk, the CPAP is on. Let's go to the theater. Section 3 covers the operations. The text emphasizes that the open cut-down surgery is history. This is a laparoscopic game now.
And it's combined with ERS protocols, enhanced recovery after surgery. This is modern perioperative care. We don't use catheters if we can avoid them. We avoid central lines. We get these patients up and walking within hours of the surgery. Yes. You operate on a 150-kilogram patient in the morning, and they are doing laps of the ward by the evening. It drastically reduces clots and chest infections.
Let's break down the big 3 operations described in the chapter. First up, the most popular procedure globally, the sleeve gastrectomy.
The sleeve. It currently accounts for about 46% of all bariatric procedures worldwide.
I like to visualize this as the banana.
That is the perfect visual. You place a calibration tube called a bougie down the throat and into the stomach. Then you use a stapler to cut and seal the stomach vertically alongside that tube.
You remove the outer part.
You remove the greater curvature, about 80% of the stomach. You fish that piece out of the abdomen. What's left inside is a narrow tube of stomach that looks like a sleeve or a banana.
Now, originally people thought this worked just by restriction. Smaller stomach equals less food. But Baily and Love says that is too simplistic.
It is much more elegant than that. The sleeve is a metabolic operation. By removing the fundus, that's the stretchy, dome-shaped top part of the stomach, you are removing the body's primary factory for ghrelin.
Ghrelin being the hunger hormone.
Exactly. Ghrelin makes your tummy growl. If you cut out the ghrelin factory, the patient's hunger drive plummets. They just aren't hungry.
I see.
Also, because the stomach is now a narrow tube, food shoots through it much faster. This rapid transit stimulates the intestine to release other satiety hormones.
But every hero has a weakness. What is the Achilles heel of the sleeve?
It is the angle of his.
The angle of his. Sounds like a location from Lord of the Rings.
It does, doesn't it? It's the anatomical angle between the esophagus and the top of the fundus. The tissue there is very thin. It's right up near the spleen. It is technically tricky to staple securely.
Okay.
Now, consider the physics of the sleeve. You have a narrow tube, but the exit valve at the bottom, the pylorus, is left intact.
So it's a high-pressure system.
Exactly. When the stomach contracts, the pressure builds up. If there is a weak spot at the top at the angle of his, that pressure can blow it open. A leak here is a disaster. It's very hard to heal because the pressure keeps pushing gastric juice out.
And the other consequence of high pressure is reflux.
Correct. If you squeeze a tube under pressure, the contents have to go somewhere. Often, they go up into the esophagus. The text warns that long-term acid reflux, or GRRD, and even Barrett's esophagus, a precancerous change, are significant risks after a sleeve.
Which leads us to the gold standard, the Roux-en-Y gastric bypass. This anatomy is a bit more complicated to visualize, so let's take it slow.
Think of the bypass as a diversion. Step 1. We create a tiny stomach pouch at the very top, about the size of an egg. We cut completely through the stomach, separating this pouch from the rest.
So the big stomach is still there, just disconnected from the food stream.
Yes. It's sitting there, minding its own business, getting a blood supply, but no food ever goes into it again.
Okay. Step 2.
We go down the small intestine about 50 to 100 centimeters, and we cut the bowel. We bring the bottom end of that cut up and attach it to our little egg pouch. This is called the roux limb, or the alimentary limb.
Okay, so food goes from the mouth to the pouch and straight into this limb.
Correct.
But what about the digestive juices? The bile from the liver and enzymes from the pancreas. They are still flowing into the old stomach and the top of the intestine.
That is the other side of the Y. That limb, the biliary limb, carries the juices down. We connect it into the roux limb further down the track, usually another 100 to 150 centimeters down. This connection is the common channel.
So food flows down one side, bile flows down the other, and they meet at the junction to start digestion.
Exactly. So you have restriction from the small pouch and some malabsorption because you've bypassed a chunk of bowel. But the magic is the break hypothesis.
Explain that.
By dumping undigested food rapidly into the lower intestine, you trigger a massive release of hormones like GLP-1 and PYY.
Ah.
These are the body's natural stop-eating signals. They also tell the pancreas to release insulin. This is why a patient's diabetes often improves within 24 hours of surgery, long before they lose any significant weight. It's a hormonal reset.
Operation number 3 is the new kid on the block, and it's causing a bit of a stir. The one-anastomosis gastric bypass, or OAGB, often called the mini bypass.
The visual here is a loop. Instead of cutting the bowel and making a Y shape with 2 connections, you just bring a loop of bowel up and join it to a long, thin gastric pouch. One join, one anastomosis.
Simpler sounds better, less time under anesthesia. Why is it controversial?
Because of bile. In a Roux-en-Y, the bile is diverted way downstream. In an OAGB, the bile flows right past the connection to the stomach.
Oh, I see.
The fear is bile reflux. Surgeons worry that bile splashing back into the stomach pouch and potentially the esophagus could cause severe inflammation or even increase cancer risk over 20 years.
The text mentions the long-term data is still pending, but it's a valid concern.
A very valid concern.
Briefly, let's touch on the gastric band.
It's largely a historical note now. The text describes its declining use. It's a silicone belt around the top of the stomach with an inflation port. The problem was high maintenance. You had to adjust it constantly.
Right.
And foreign bodies fail. They slip, they erode, the ports flip. The removal rate is very high.
Finally, for the super obese or revision cases, we have the heavy hitters, the BPDDS and the SADS.
Alphabet soup, yes. These are malabsorptive powerhouses. We use these for patients with a BMI of 50, 60, or more.
Wow.
The key metric here is the common channel, the amount of bowel left where food can actually be absorbed. In these surgeries, that channel is very short, maybe just 2.5 to 3 meters.
Which means massive weight loss.
But a huge risk of nutritional deficiency. If these patients miss their vitamins, they get protein malnutrition, liver failure, and severe vitamin deficits. It's a high-risk, high-reward strategy.
All right, let's solidify this with some case files. I'm going to throw a fictional patient profile at you. Based on Baily and Love, you tell me which operation is the best fit.
Let's do it.
Case A. A 40-year-old female, BMI 42. She has type 2 diabetes. But here's the kicker. She has severe, long-standing acid reflux. She's taking medication for it daily. What are we doing?
Okay, stop and think about the physiology. If we give her a sleeve, what happens?
You create that high-pressure system.
Exactly. That will likely make her reflux 10 times worse. It's a contraindication. We need a low-pressure system that diverts acid away. So for the reflux patient, the Roux-en-Y gastric bypass is the clear winner.
It fixes both problems.
It treats the obesity and cures the reflux. It's the perfect choice.
Okay. Case B. A male patient, BMI 65. Super obese. He has sleep apnea and high blood pressure.
BMI 65 is technically very, very difficult. The liver is huge. The abdominal wall is thick. Doing a complex bypass with 2 joints might take too long and be too risky. The text suggests a 2-stage strategy here.
2 stages. You operate twice.
Potentially, yes. Stage 1, do a sleeve. It's faster and simpler. Get the weight down from BMI 65 to, say, 45 over a year. Then, once the patient is safer and the anatomy is more manageable, you go back and convert that sleeve to a SADI-S or duodenal switch to get the rest of the weight off. It's about not trying to be a hero in one day.
Speaking of risks, let's move to Section 5. Complications. Every surgeon's nightmare. The text uses a very specific, very chilling phrase to describe the clinical presentation of a leak.
A feeling of impending doom.
It sounds like something from a horror novel.
It does, but it is a genuine, documented clinical sign. A patient with an anastomotic leak where the staple line has failed and gut contents are leaking into the abdomen might not have severe pain immediately, but they get anxious.
Just a feeling.
They feel wrong. They feel like something terrible is happening.
And physically, what is the telltale sign that we should look for?
Tachycardia, a racing heart. The text stresses this. A heart rate above 120 in a post-op bariatric patient is a leak until proven otherwise.
Wow.
Do not wait for them to have a fever. Do not wait for their belly to be rigid. In patients with obesity, those signs are often masked.
So if you see a heart rate of 120 and they feel doom, what do?
You act immediately. Immediate CT scan with contrast. Or straight back to the operating theater for a laparoscopy. You have to wash out the infection and place drains. Delay is fatal.
The other big killer in the early phase is clots, DVT and PE.
Yes. Obesity puts patients in a prothrombotic state. Their blood is sticky. PE, a pulmonary embolism, is actually the main cause of death after these surgeries.
Which is why we get them walking.
That's why we are so aggressive with blood thinners and getting them walking immediately.
Now, let's look further down the road. Late complications. There is a condition called an internal hernia. That sounds particularly tricky.
This is the trapdoor of the Roux-en-Y. When you rearrange the intestines to make that Y shape, you create potential spaces or gaps in the mesentery, the tissue that holds the bowel. We try to stitch these gaps closed. As the patient loses 50 or 60 kilograms, the fat melts away, the stitches loosen, the gaps open up. A loop of bowel can slip into that gap and get twisted.
And the bowel dies.
It strangles. The classic presentation is severe, cramping abdominal pain that comes and goes.
Oh, it goes.
It comes and goes because the bowel slides in and out of the trapdoor. And here's the scary part. A CT scan can miss it. If the bowel isn't trapped at that exact moment of the scan, it looks normal.
So what do?
If a bypass patient has unexplained severe pain, you often have to do a diagnostic laparoscopy to find it. You have to go in and look.
Finally, we can't talk about these surgeries without mentioning nutrition. We are rearranging the plumbing so absorption changes.
It is a lifetime commitment to supplements. Iron, B12, calcium, vitamin D. The text also specifically flags folate.
Why folate specifically?
Because fertility often returns rapidly after surgery. Obesity causes hormonal issues like PCOS. When the weight drops, ovulation returns. Women can get pregnant unexpectedly. If their folate is low, the baby is at risk of neural tube defects like spina bifida. So contraception and nutritional counseling are massive parts of the post-op care.
We're heading into the home stretch. Section 6 focuses on outcomes. Does this surgery actually pay for itself?
Financially, yes. The text quotes data showing the surgery pays for itself within 2 years.
That is incredibly fast for a major medical intervention.
Think about the cost of insulin, the cost of blood pressure meds, the cost of CPAP machines, the cost of treating a heart attack or dialysis. You wipe those out, and the healthcare system saves a fortune.
But it requires a shared care model.
Yes. The surgeon can't do it alone. The GP, the primary care doctor, needs to be empowered. For example, if a patient is on high doses of insulin and they have a bypass, their insulin needs might drop off a cliff within 24 hours.
Wow.
If the GP or the patient keeps taking the same dose, they will go into hypoglycemic shock. Medication must be deprescribed aggressively.
And the follow-up isn't just, see you in a month.
It's forever. 3 months, 6 months, 12 months, and then annually. Lifelong. We are managing a chronic condition with a permanent anatomical change. You cannot ghost your surgeon.
So let's wrap this up. We have covered a huge amount of ground today. Baily and Love, Chapter 68.
Let's do a final recap. What are the big 3 takeaways for our listeners?
Okay.
1. The physiology. Obesity is a disease of the homeostatic set point. Surgery resets the thermostat, diets fight it. 2. The anatomy. Know your sleeve, the banana high-pressure reflux risk from your bypass, the gold standard, metabolic reset, internal hernia risk.
Got it. And number 3.
3. The warning. Impending doom plus tachycardia equals a leak. Don't think, act.
And I want to leave the listener with a final thought from the text that I think is really powerful. It challenges us on language.
Yes. It explicitly discusses obesity stigma. It urges us to use person-first language.
So what does that mean in practice?
We shouldn't say the obese patient. We should say the patient with obesity, just like we say the patient with cancer or the patient with asthma.
It's a subtle shift, but it frames obesity as a disease the patient has, not who the patient is.
Exactly.
And considering the plague proportions of this disease, removing that stigma is probably the first step in getting more people access to this life-saving treatment.
Absolutely. If we treat it as a moral failing, we deny treatment. If we treat it as a metabolic disease, we save lives. And as surgeons, we are in the business of saving lives.
That is the perfect place to land. This has been a deep dive into Baily and Love, Chapter 68. Please go read the chapter, look at the diagrams. Use this episode as the map, but you still have to walk the path.
And remember, in surgery, knowing why you are cutting is just as important as knowing where to cut.
Thanks for listening. We'll see you on the next deep dive.
Goodbye.